Great, welcome back to the House Healthcare Committee for our afternoon session. It's about 1:18. We're sticking with the fiscal year 25 budget. And so we heard from VDH earlier. That was the VDH budget that was part of the governor's budget ask. The next couple we're going to hear from were not included in the governor's budget. And so it would be new to us if we choose to move forward with it. And so we have the Vermont Public Transportation Association, or otherwise known as the Non-Emergency Medical Transportation. So we have Jim Moulton, Elaine, I'm sorry.
Heiko, it's okay.
Heiko, okay. So I'm going to turn it, I don't know who's going to go first or if you're doing this together, but I'll turn it over to you.
Thanks so much, Chair. We appreciate the opportunity to come before you and the committee to talk about the non-emergency medical transportation that we do for the statewide Medicaid program. My name is Jim Moulton. As you noted, I am the Executive Director of Tri-Valley Transit. We serve Addison County, Orange County, and Northern Windsor counties. I'm also the chair of the Vermont Public Transportation Association, VPTA, chair of the board, and Elaine is our executive director, and I'll let her do a more full introduction. And then we have a brief presentation overview of the NEMT program for you, and we're happy to take questions at that point.
Great.
So as Jim mentioned, I'm Elaine Heiko, the executive director, and I serve as the statewide broker for the NEMT contract supporting the public transit transportation providers statewide, except Advanced Transit. They're the only one who doesn't do Medicaid. So
okay. So this is strictly around Medicaid, this presentation. Okay, great.
So if I might, I would like to share my screen to do a PowerPoint.
She's gonna let Claire's getting, you should be able to now. Yep, great.
All right, so you can see that?
Yes.
Perfect. So the NEMT, again, non-emergency medical transportation, and we provide that service for all of Vermont. As Elaine mentioned, VPTA itself is the central statewide broker. And then, as well as my role as the chair of that board, I am the executive director of one of the primary providers of that service. The other VPTA members, as Elaine mentioned, except for Advanced Transit, are all providers of the service. Let's see. So we are facing, as the title of this says, a fair number of financial challenges. These financial challenges are driven by a lot of changes in the profile of the riders and the profile of the circumstances that they're facing, and the profile of behaviors that we've seen since the pandemic came into play. All right. So one element, just to frame it for everybody, the NEMT program provides funds to the providers through a kind of an unusual mechanism called either the PMPW or PMP which is the per member per week or per month rate. We typically use week as our baseline, but it can also be framed as a per member per month. So like, say, a general insurance program, there's a premium paid into the system on behalf of each member. The members in this case are not folks, they have to be obviously Medicaid eligible, but they also have to be eligible specifically for the transportation benefit. So there's once you're in the Medicaid program as a member, there's a higher standard that needs to be met in order to be eligible for transportation. Primarily, it means you don't have a car in the household. If you do, it has to be accounted for in terms of being used by other people in the household. There's a fair number of elements that have to be met. So there's a relatively limited number of people in the NEMT program, as shown by this graph. And in particular, the numbers have shrunk since 2020 and are down relatively, substantially. While the per member per month or per week rate has increased some since then, it has not kept pace in terms of generating the revenue needed to offset a whole bunch of increasing costs. So the unit costs, as I referred to just now, have been rising during that time. Many of you may know that volunteer drivers are an essential part of the program and the lowest cost option. Vermont is actually one of the leading states in the nation in terms of its use of volunteers to provide service. And they volunteer their time, they use their own cars, and we reimburse them mileage only. The mileage reimbursement rate has risen by 20% over the last 3 years. That mileage rate is set at the federal level by the IRS and the GSA, the General Services Administration. And we've also seen, since the pandemic, a substantial drop in the number of volunteers in the state. We were, Elaine, you can clarify for me, pre-pandemic, we had how many volunteers across the state?
430. We're down to
So,
150.
more than 400, and we're down to 160, you said?
Mhm.
So there's been a huge drop in the number of volunteers. And as noted, it is the lowest cost option. But with fewer volunteers, we are then forced to provide rides under the entitlement of the Medicaid program at more expensive, through more expensive modes, whether those are taxis or whether those are staff drivers using vehicles such as vans or even sedans. It's just when we start getting into staff wages, that it becomes more expensive. Over the past 5 years, there's also been a significant increase in wages around the state. I don't think I'm saying anything differently than every industry has experienced. My organization happens to be a union shop. There are a couple of others in the state. Not that the unions are specifically driving the increase in expenses, but as a negotiating entity, they do have a lot of ability to impact the labor market. We've seen a 30+ increase in wages across the state for just keeping the staff that we have in place and even trying to be competitive. We've, like a lot of industries, it's been difficult for us to stay fully staffed. One of the outcomes of our inability to be as fully staffed as we would like to be is that we then start to get into not just the cost of staff delivering the service, but also those hours of service often come at time and a half. So there's sort of this increasing level of pressure going from mode to mode to mode that has been exacerbated by the effects of the pandemic, the lasting effects of the pandemic. Administrative costs have also risen. While I would say administrative wages have not risen, certainly there have been costs there. And there have been a lot of additional burdens in our new manual. This is the guidance that we have in collaboration with the Vermont Health Access Department to deliver the services. They provide us with the direct guidance. There's a lot of rules and regulations that come down from the federal level. Those burdens of tracking, reporting, and delivering the service have gone up. An example of that would be what we call NOD letters, NOD. These are notices of denial. If a rider requests a ride at a certain date and certain time, and we are unable to provide it for any reason at all, we have to issue what's called a notice of denial. And often we have to do 2 of those in order to satisfy the requirements under the guidance. It is a lot of additional administrative work. The intent is to make sure that riders understand that their ride wasn't able to be provided and the reasons why it wasn't able to be provided, but it does add a fair amount of work to the process, and it's typically done by paper since many of the clientele that we serve are not able to access easily electronic versions of this. The pandemic has also, as I think you've probably heard in other arenas, created a lot of behavioral problems for a lot of our riders. Some of that can be as basic as no showing, meaning they've scheduled an appointment. We will send a resource out there, whether it's a volunteer or whether it's a staff driver, and the rider isn't there and has not communicated with us. That is an expense that we bear without actually having to been able to deliver the ride. We've seen, as I mentioned, an extreme change in behaviors of a lot of riders. Again, the opioid epidemic is not new information for this committee, but it has had an extreme impact upon how we are able to deliver services successfully. There's a definite increase in difficult behaviors by riders, making it harder to provide the service. An example is that a volunteer driver, because they are volunteers, can say, I don't want to transport certain people. They are too difficult for me to provide the ride, which is, again, a more expensive mode. We might, in our efforts to coordinate rides to keep costs down, we can get a lot of inter-rider behaviors that become unacceptable, which then forces them back out into multiple vehicles when they theoretically could stay in a coordinated group. So there's a lot of increased costs just because of behavioral issues. And then the disruptive behavior also causes a fair amount of administrative time being spent on following up on these behaviors, investigations of what they are. Can they be denied service? If not, what are the limitations that we have to put in place? And it creates behavioral contracts sometimes. Just a fair amount of additional work that exists now that didn't exist pre-pandemic. The graph on the right-hand side, you can see that the cost of service per member has risen substantially over the past 4 years in particular. The usage rates by the individuals in the program has also been rising. In this chart, we talk about two groups of users. One are super users. These are folks that use at least 10 trips on average per month, or hyper users, those who use at least 20 trips per month. The charts essentially show that a very small group of members, whether they are super users or hyper users, that group has grown in terms of how many of our total members are in those groups, and the volume of rides that they consume compared to the whole program is enormous. You can see currently in fiscal year 24, 11% of the total number of members are super users. They use 63% of that 20 trips per month, which is a lot when you think about that. That's, trips every week, multiple trips every week. 7% are using almost half of the entire system. So between the fact that the total number of people in the pool has shrunk over the past few years, exacerbated by this growing use of the program by hyper users, has created this dynamic where the revenues generated by the simple math of what's the rate versus the number of people isn't generating enough revenue to cover the costs, especially given all the cost pressures that I just talked about.
So Jim, can I just stop you there real quick? I just want to make sure I'm hearing this right. So you get paid on a per member per week or per month, no matter how many rides they take. So, so you get paid for me one time, but I might take 20 rides. And the overall, your membership is shrinking, which is causing the revenue to be less, but the rides are increasing because the people using it are using it many, many times.
Correct.
Okay.
And interwoven with that is the fact that all the externalities that have driven costs up, whether it's
Right.
gas prices, volunteer mileage rates, labor rates, administrative overhead, all of those costs are exacerbated by what you just described.
Okay. We have another question, Alyssa and Melanie.
I'm sorry, maybe I'm being obtuse. I'm not quite understanding this chart. How can you have more than 100% of rides in 2024?
Sorry, no, yeah, it's not necessarily the hyper users are a subgroup of the super users.
Oh, okay. Oh, that makes more sense. Like,
Yeah, no, that you make a great
Percentage.
point. It's yeah, it's one of the issues of when you're in it all the time and you understand the data and information, you forget that it may not be as clear and transparent as you want it to those of you who aren't living it and breathing it every day. So yes, the 7% is a subgroup of the super users, the hyper users. So
okay, got it. Thank you.
Melanie, did you have a question?
I did. I was just curious, is the decrease in the number of members due to the re-verification program that we're seeing in Medicaid? So we're having people move off of Medicaid, so they're not eligible to be a member, but the need's still there. I just was wondering what that drop.
Yeah, do you know why it's dropping the number of members?
So certainly, during the pandemic, when eligibility requirements were suspended, there were certainly more clients in the system. And now that we're beyond that, and the agency has been examining the eligibility of all the people who were in the program, there's definitely a certain impact of, as the number of people are moved off Medicaid rolls, they are no longer eligible for this program. We may still be serving them, and often we are, because we have another primary program through the Agency of Transportation for older adults and people with disabilities. That doesn't cover, obviously, all Medicaid riders, because many Medicaid riders are under the age of 60 or don't have a qualifying disability, but there's still, a relatively fair amount of overlap. So it will end up shifting that cost onto that program, which has a limited amount of funding. But then it also is, with the fewer number of people in this program, in part driven by that. So it lowers the amount of revenue being generated by that multiplication method of the rate times the number of people.
We have one more question, Alan.
Yes, what's the main reasons for someone to be using 10 trips per month or 20 trips a month?
The opioid epidemic, just point blank.
I'm sorry, we didn't hear you. Can you say that again?
The opioid epidemic.
Okay,
Um,
so they're getting rides to their appointments, or?
Right. There are,
Okay.
it's a daily treatment. So we are carrying people on a daily basis to treatment sites that sites are typically longer distance trips. And so it makes the length of time greater, the number of miles greater, all of which are cost multipliers. And it also gets back to some of the behavior issues we're talking about, in terms of this is a clientele that struggles, and it can create behavioral issues between riders. It can create behavioral issues between riders and drivers. And those issues create that cascade effect of typically putting them onto more expensive modes of transportation. I will say, just as one small example, out of Bradford, we are sending a vehicle with 13 people for treatment on a daily basis. It's it went from being essentially nothing to now it's overwhelming. And I think Elaine could probably share even more stories on the statewide basis of the impact of the opioid epidemic on the number of people and number of rides we're providing for that.
So, and I could just ask a question about that. We had the Commissioner of Department of Health in here earlier, and he mentioned, Addison doesn't have a hub. So would the transportation agency in Addison be taking people to a hub in Chittenden County per se, or wherever they need to go. Okay, thank you.
Exactly, yes.
Okay. All right, I think,
Just an example, here in southern Vermont, in Bennington County specifically, the hub closed just before the pandemic. They now travel to Brattleboro to support people with the opioid epidemic. They travel to Rutland, and they travel to North Adams, Massachusetts every day to bring people to dosing.
that's
Those
helpful.
Yeah, just to put some light on.
Yep, thank you. Okay, we can go back to slide 4 or wherever you are.
All right. I think we've covered everything in this slide. You know, the story really is about the super users and the hyper users. Other factors, I probably referred to a number of these already. The longer trips consume volunteer resources and push more trips onto agency vans. You know, effectively, a volunteer may be willing to put in a fair number of hours in a day, but if they're on one trip that's far away, then they're not available for a lot of other trips. And those shorter trips then get forced onto other more expensive modes of transportation. And the other element of having roughly, well, fewer than half of the volunteers available to us now that existed pre-pandemic, is that those volunteers are being pushed hard. They're driving a lot. They are getting burnt out. They are now telling us that there are many rides that they won't do, whether it's because of behavior issues, whether it's just from sheer exhaustion. So again, that forces people onto more expensive modes of transportation. That also has a cascade effect. We even have paid staff drivers who will either be forced into overtime, but even after a certain period of time say, I don't want to do this anymore. It's too exhausting. I can't keep working, 45, 50, 55-hour weeks. So it then creates more NODs, more nods, more notices of denial, because we aren't able to provide the trips at the exact moment and day that somebody might need the service. It's amazing in some ways to me, the level of cascade effect of all of these things. Any one of these individual items that I'm talking about, in and of itself, historically, agencies have always been able to solve. We'll hire more drivers, we get them on board. We'll recruit more volunteers, we put them on board. It's just we are so far behind the 8 ball with those things and all these other elements going on that the combination has just kind of reached, I'll use that sort of trite phrase, the perfect storm. We are just overwhelmed. Go ahead, Elaine.
Can I add just a little bit?
Sure.
I think, yeah, we have to also consider the fact that this is happening in other agencies. We don't have as many specialists as we've had in the past, which means we're getting more and more referrals through VBTA to send to every provider to provide trips over 100 miles. We also have dialysis units that are now staying open till 10 o'clock at night to meet demand. We're also bringing people for dialysis 3 times a week out of state because we can't meet the demand here. So that there's cascading effects with the fact that we don't have a lot of specialists. We're going to Boston on a daily basis almost now. And this just continues to grow and grow, which is very different than it was pre-pandemic. It's sort of our service has really worked into something very different than it was.
Yeah, sounds like it. What I'd like Jim to do is finish his presentation because I want to get to the ask, and then we do have a couple questions.
So we're almost there. So
That's fine,
priority has been given to in-bed treatment centers and these so another element of the opioid epidemic, where people who are leaving treatment have been hyper prioritized because they don't have a place to stay. They need to get out. That disrupts the schedules of, we had a recent incident not in my area, I'll say thankfully for me, but another region where someone was being discharged. The treatment center that was discharging them absolutely refused to be able to reschedule the time of that person's discharge to their place of living. The provider had to disrupt 6 other rides in order to provide that, one of which was a dialysis trip, which ended up being provided by a staff driver to get that person to their dialysis treatment. And learned after the fact that there was also a person who was disrupted who had a high complication pregnancy and needed to see their practitioner and had to have that rescheduled. So there are lots of impacts and lots of cascade effects that go beyond even just what I'm focusing on heavily, which is cost. So we have, our conclusions here. You've basically heard them already. Flat membership levels, increased unit costs, impacts of super and hyper users without an adequate buffer. We are already not going to receive adequate funds in fiscal year 24 to cover the cost substantially. We've been working closely with the DVHA administration to address this and been in close conversation about the dollar figures for FY24 and potentially leading into FY25. I think it's a very collaborative effort. They recognize all of the things that we just spoke about, and so we are looking at a minimum of even above. So to sort of be also as I guess explanatory as I can about the contract, the rate, and the amount of money. The amount of money that's currently appropriated in the fiscal year 24 state budget is $14.5 million. Because of the mechanism that's being used of rate times number of members, we're not going to draw down that amount of money under the current situation. The multiplication works out to about $13.5 million. And if it were left alone, we would be losing at least $1 million right there across the state. As I mentioned, we are working collaboratively with DVHA officials, and I think we feel positively that there's an ability to change that rate and make that math work out. We did happen to do that last year with them, so there's a precedent for that. The second is even beyond the 14.5 million. We track expenses. Every agency is tracking them monthly, but in particular for this program on a quarterly basis, we report out. After the first quarter, it looked like expenses across the state would be about 14.8 million, and what I would call sort of within shouting distance of that. After the second quarter, if we just took that 6-month period and projected out equivalent to the next 6-month period, we would be over $1 million behind that $14.5 million figure. So we are in the process literally right now of going back to all of our providers, looking at our expenses, determining final Q2 information, and looking to project as accurately as we can to the best of our ability what Q3 and Q4 might look like to understand what that gap might really look like. As far as FY25 goes, whatever is happening right now, we don't see anything that is changing that in terms of, lowering the cost or, that's really what it comes down to at this point is that, so there's also the 25 cascade effect that we will need to address.
Okay, so I want to stick to the ask. I haven't forgotten about you two. It's about the money.
It's about the money. It's about the ask, the first part of the ask. So are you telling me that in the budget, it's appropriated 14.5, but because of the per member per week methodology, you're only able to get like 13 point whatever for that? That you're leaving $1 million on the table?
So there's two pieces. I really want to be make sure that I'm communicating as clearly as I can. There's the first step of this is the disconnect between the current rate and the number of members, and the multiplication there generates to an estimated 13.5 million. If we are able to change the rate, which is something we are, working collaboratively with DVHA, and I think it's fair to say that we're hopeful about this. We could draw down the full 14.5 million that exists in the current FY24 budget.
Okay.
However, that only gets us partway there because
No, I understood that.
But I keep going.
I don't,
Keep going.
so.
Keep
sorry.
going.
so again, from that point above the $14.5 million threshold, we were seeing us more or less on track through Q1, a certain amount of over cost, but Q2 it has accelerated. We are uncertain yet what Q3 and Q4 look like. Historically, they've never been below Q1 and Q2. But if you took the first 6 months and said double it, the cost would be 15.5 million. It would be a minimum of an additional $1 million. I will tell you truthfully that, I would like to be asking for just enough for the organization, for all the providers to break even. We only ever looking to break even in this program. We are not looking to make money off of it. And I want to be cognizant of that, but I also want to be cognizant that we don't want to under ask and then end up losing money. That happened last year. Unfortunately, there was a lot of good faith that went into all the parties involved, with the DVHA officials, with the providers, with the legislature. Additional funds were provided through the Budget Adjustment Act last year. In the end, costs continued to accelerate at such a rate that we ended up losing about $170,000 statewide on the program. And we just don't want to be in that situation. So I can't tell you definitively in this moment, is it 1.1? Is it 1.2? I can share that it's in that range. And we are looking to define what that amount is so that we can be as transparent in this process as possible.
Okay, that's helpful.
Ask one more
Yeah,
clarification on that. So that 1.2 or 1.5 for the anticipated Q3 and Q4, that is if you're able to pull down the whole 14.5?
Correct.
Okay.
That is correct.
So if the rate change doesn't happen, then the ask could be more, because we wouldn't have pulled down all the federal funds.
Correct. Although there is already in the budget appropriated the 14.5 million. So it's just a matter of what's the mechanism to access those funds. Again, I believe that will be worked out with DVHA officials. I don't perceive that there's any barriers to that. I don't want to speak on behalf of the officials because I don't know all the nuances of their mechanisms to understand what, where and when there might be barriers, but the good faith is absolutely there. So in my mind, anyway, our true ask is above the 14.5 million, because I do feel at this moment that it seems plausible that we will be able to access the missing $1 million so far.
And just to confirm, Jim, your fiscal year starts July 1st. So you are currently in
We're on.
the third quarter. Okay.
Correct.
Okay. I want to go back to the questions, but I think, Leslie, do you have a financial question?
Yeah, I'm sorry that I'm confused.
Okay, I'll explain it.
Okay, that's great. There's a chart in here on page 69. It says transportation. Is that this?
I don't know what you're looking at.
Looking at this?
That is that.
Great. So I mean, that's just so that's what's 24 plus the BAA on page 69. I'm just trying to understand, because I hear your work is incredible and really important. I'm just trying to understand the ask and what's driving it. I'm having a little hard time with that.
Okay, so the ask could be potentially two things. So in the fiscal year 24 budget that was passed out of here, which we are in February now,
Yeah.
they are budgeted to receive $14.5 million. However, how they're paid by the state for this service is they take a rate times the per member per week. That is only estimated to be at 13.5 million. So potentially there's $1 million in the budget that DVHA and them could work on and just say, yep, you're going to get that $1 million. Okay, so let's assume that happens. They're working on the costs right now. They believe they're still going to be short $1 million for the remainder of the year. So the ask would be for next year, for fiscal year 25, to put in approximately $1 million.
And the ask would be 15.5 million?
Yes, potentially, yes,
Okay.
if they want $1 million more.
Okay.
Right,
Yeah.
or if there's no agreement made with Diva on this $1 million that's sitting out there in the budget, we might have to also step in and say, well, we would like that $1 million to be allocated, appropriated, and so that's that second piece of it.
So the rate is a rate per ride.
No, it's a rate per week.
No.
So I'm a member and I
Okay.
call up and 20 times during the week to get a different ride. They are only paid $195.
Because of that one thing.
Yes.
Got it. Thank you.
Melissa?
I still have. So,
Yes, I know. I'm getting there.
I just, what you just said, you're short, essentially you're saying, because your fiscal year ends in June and you're going to be short another $1 million. So essentially what you're saying is it costs 15.5 million to run this program, but you're going to be short $1 million. So really, are you asking for an appropriation of 16.5, which is 2 million more than what you, is it?
No, because there's
Because you
$1
gotta
million,
make
there's
up-
$1 million in the budget that potentially may not be spent.
So, no, the question is an accurate question.
Okay.
If
Yeah.
if I'm understanding the process correctly, given that the BAA has moved, out of the house, it is not a mechanism for our current fiscal year,
Okay.
then potentially the big bill could reflect, just using these round numbers again, a $16.5 million appropriation.
Because that
1
is your true
million,
cost.
because that's our true cost, of which 1 million might go, well, so 15.5 is the true cost.
Right.
1 million of that 16.5 would be to offset this year's losses with the
Oh, that's right,
15.5 million.
Okay.
Correct.
2.5 million is the full cost as of this point in time for this program. But
In
you're
the
$1 million.
manual, in this year, yes, in this year, correct. So the question is correct that the ask really could be 16.5 million in the big bill, with the concept that knowing $1 million of that is to offset current year costs since the BAA is not the mechanism being used.
Okay. Right. We got to work on whether or not we go backwards or not. Okay. That's helpful. Okay. Mari and then Alan.
Back on the slides when you were talking about more when you can't, for the more expensive ride options, you have to pick that up. Who pays for that? Where's the money come from?
So, can you tell me which slide page that is?
I can't remember exactly which one, but you said when there are situations where something pops up and the dialysis, you weren't able to take the dialysis patient, so you had to use a more expensive transportation modality. Like I'm making things up, like Uber or something else. Your organization has to pay for that?
Yes. So one element that I didn't necessarily make particularly clear is that this is an entitlement program. In other words, we are not able to deny ride. We're not supposed to deny rides. Obviously, there are some denials, but those denials are based on capacity only. And it doesn't mean that we don't still have a responsibility to provide the ride. Typically what happens is that it gets rescheduled to a different time. So if I'm a rider and I say, I need to get to the pharmacy today and I want to get there today, and I say, I don't have any way of getting you there, can you go tomorrow? That is actually called a denial, which creates the paperwork problem. But then I actually still provide the ride the next day. In the example you were just citing, the one about the dialysis patient, that is on this page where it says priority given to in-bed treatment center, where the priority of that discharge was so extreme that we ended up the provider ended up taking a volunteer who was scheduled to provide 6 rides across a whole morning and reassign that volunteer to take this long distance trip all the way from southeastern Vermont to northwestern Vermont. And then it left those other 6 rides without drivers. 4 of them ended up being outright canceled for that day and had to be either rescheduled or the rider gave up. One of them was for dialysis, which then was done by the dispatcher staff. And the last one was, I forget how it was provided. It wasn't my agency, so I don't have all those details. But that's the example where the cascade effect of expense, disruption, et cetera, goes on through this. But because it's an entitlement program, in contrast, the older adults and disabled program under the Agency of Transportation, there are limitations that we are allowed to put on in terms of numbers of trips that are provided in any given month. We don't have super users. We can control that. And we can also control the types of trips they go to. The priority is always on critical care, whether that's dialysis, cancer treatment, adult day, or MAT treatment. But we aren't required to provide trips to grocery stores. We want to. Food is important. Access to nutrition is important. Excursions are not allowed. But other daily elements of life, whether it's getting to work, whether it's getting to see an attorney, whether it's, again, grocery shopping, meal sites, but we're allowed to put limitations on those items through that program. Medicaid, CMS rules don't allow us to do that. So the volume is the volume.
Yes, thank you.
Alan?
Well, I think it's been answered about 8 different times. The users of your service, do any of them have to get providers okay for your service, or because they're a member, they can call you anytime?
They can call anytime up to the same day at the close of business and request a ride. And if a MAT user goes daily for services, they can also take rides for their regular doctor's appointment, their dentist, whatever else they need that's a Medicaid billable ride. There's no cap or limit on how many rides a member can take.
Thank you. I want to clarify one thing on if you can put down the slides so we can see your face, that would be great. I want to clarify one thing. So we're potentially talking about a $2 million ask, but if it's Medicaid, is that gross or state dollars? Do you get matched?
Yes, those dollars are drawn down at the same ratio as the rest of the Medicaid program. I think it's something like 57.5% federal and
Okay.
42.5% state. So it's at that same exact ratio.
Okay, so it's the 2 million is gross, so the state dollar ask would be less, and we can have Ellen figure that out for us. Okay, any other, Melanie?
So just so that I'm getting the numbers correct in my head, so I believe that your the FY25 budget is level funded going forward. Is there something that we should be adjusting to make that reflect what we're doing here besides the ask to get caught up?
So I think go ahead, Jim or Elaine.
We certainly would like to do that so that we don't have to do this again over and over. And just to clarify, we're over $1 million behind 6 months in our budget. We are working with DEVA to catch that up in the PMPW rate. We hope to have a projected budget by the end of this week to let you know what our projections are for total losses for FY24. And then if we can adjust for FY25 so you don't have to spend so much time with us, that would be great.
Oh, we like having you here, but we got that. Leslie?
Yeah, thank you. And I'm sure this is not the time, but I'm curious to know DEVA's thoughts about going forward and how that's gonna.
So we had asked DEVA when they came in for the budget presentation to come back to us with their analysis of what this would cost.
Mhm.
So we are waiting for that.
Okay,
Yes.
great. Thank you.
That isn't in the DEVA book, is it?
This is in the DEVA book, but we asked them to come back. They did not, there was nothing in the governor's recommend to increase this budget. And so we had asked DEVA to come back with an analysis of what they think the cost would be. So we'll look at that. We'll look at what Elaine and Jim send us when you have your final costs, and we'll put it on the table. So, great. Any other questions? Thank you, Jim and Elaine, very much, and please.
Thank you very much for the opportunity. I think you can tell we care deeply about the program and want to provide this for, all the Vermonters that need it. But we have to do it in a financially responsible manner. And I wish we didn't have to come here for the ask, but it's our reality because of the entitlement nature of the program. So thank you very, very much for your time.
Great, and please thank everyone who's doing all this great work from us.
You will.
Okay, great.
Thank you.
Thank you. I don't think we're going to take a break. We haven't been sitting here for 45 minutes, so we're going to keep on going. So we have a Vermont Medical Society, and with Susan is
Susan's joining remotely.
she's in Zoom. Okay, so we'll let her in. And so again, this is an ask not included in the governor's recommended budget from our provider network.
It is. Thank you. Jessa Barnard with the Vermont Medical Society, and also speaking on behalf of the Vermont Academy of Family Physicians and American Academy of Pediatrics. And our testimony will really be aligned with Health Firsts also. We're largely here together to say the same thing, but Susan may have some comments to add after I do. And this is not a new concept to your committee. This is basically we were back in the same issue we were here talking about last session when you, if you recall, you did direct additional funds. This is what we're talking about is Medicare's, Medicaid's lovely term, their RVS fee schedule. It's really their professional services fee schedule. So like medical appointments, you're going like doctor's appointments, mental health, certain mental health providers are in that category. And it is largely, again, sort of outpatient services. And last session, you directed the primary care component. The fee schedule is sort of one fee schedule, but they do have an enhanced payment already. Medicaid for years has had an enhanced payment for primary care services. It's sort of a two-part test. If you attest to being a primary care clinician, and then a list of primary care services within that. So to that enhanced part of the fee schedule, last session, you directed that to be reimbursed at 110% of Medicare. And then you added a 3.8% inflationary increase to the specialty, well, basically everything but that. I'm referring to it kind of as specialty services, but remembering that services primary care provide that are not on that list are also in that bucket. So that's a lot of e-services, other substance use disorder services, things that are not, routine appointments, but if it's to a specialty provider like endocrinology, cardiology, that's sort of the non-enhanced primary care fee schedule. Part of the reason we are back here is that this fee schedule is based on Medicare's fee schedule. It really mirrors Medicare's formula and Medicare's payment rates. And I don't have to go into detail. I did include a picture of how they come up with that fee schedule because I know there's been reference to conversion factors. So if you want to look down at the bottom of my first page, it talks about how it's kind of it's a multiplication little formula where they take a amount of work that so this would be, now that you've learned about CPT, it's an office visit, like they would do that, to each CPT code, they give a work component. So how hard is this to do? A practice expense component. So how expensive is it? What are the expenses that go into providing this service? And then a malpractice factor. So those are all numbers like a 1 or a 0.5 or a 0.75. They add that up and then they multiply that by a dollar amount. They have a conversion factor. So that could be, and that conversion factor is consistent for that whole year for all of those services. So that may be, $40. So they add up that amount, multiply it by $40, and that's what they pay for each CPT code. And so
A is Medicare.
A is Medicare, but also Medicaid, because Medicaid really takes those, what they call the RVUs, the relative value units, those numbers. And then that conversion factor fluctuates. So if they were to pay 100% of Medicare, and I think I'm correct about that, then it would be the same conversion factor as Medicare. But if they're paying more than Medicare, it would be a greater conversion factor. If they're paying less than Medicare, it would be a lower conversion factor. So that's how to turn sort of the work components into a dollar amount. So right now in primary care, for example, you're actually above the Medicare conversion factor because you're at 110%. But for specialty services, it's below the Medicare conversion factor because that's at about 85%. The problem is Medicare is cutting this fee schedule. So it was reduced last year, and it was just reduced on January 1 by 3.4%. So this same, what they call their physician, it's called their physician fee schedule in Medicare, though it's not just physicians. Again, it's sort of a professional services fee schedule. Was just reduced by 3.4%. So again, there's been a Medicare cut. And also, so two problems with that fee schedule. One is it's been getting cut. The other, it does not contain an inflationary factor. So even if you are matching 100% of Medicare year over year, and even if Medicare wasn't cutting it, that fee schedule wouldn't necessarily increase due to inflation. It may increase for other reasons. They revalue the codes. They may say the work factor is increased, but it doesn't include inflation. So at the federal level, many national medical societies, the American Medical Association, the American Academy of Pediatrics, all these organizations are trying to work at the federal level to say this fee schedule needs to be fixed. Not only, please stop the cuts. And there may be some hope, but I'm feeling less and less optimistic about any effort to kind of retroactively not cut the Medicare professional fee schedule this year. Plus also long-term get inflation built into that fee schedule. But as of now, we are not seeing a federal fix on the immediate horizon. So absent, and as Chair mentioned, currently this fee schedule, so in the BAA, it was basically level funded. Actually, it was a slight decrease due to some of those Medicare formula changes. And then there is also not an increase in the FY25 budget. So we don't, DVA would typically be scheduled to make another update in July to this fee schedule. So with the new fiscal year to catch up to match Medicare. So it is very likely that is when the 3.4% cut that Medicare, if that doesn't get fixed between now and then, there would be that cut, plus also not include inflation. So our request is to direct the 4.6% Medicare Economic Index, the federal measure of sort of medical inflation, to over current current calendar year, over 2023 calendar year rates. So basically the fee schedule we're on right now, which will go until end of June. So in your next budget, add the inflationary rate on top of that. Because if you otherwise caught up with Medicare and didn't say do it over current rates, there's going to be, even if you added inflation, that inflation would be on top of a 3.4% cut. So it would basically be more roughly budget neutral.
So
Yeah, sorry, I know that's complicated. A lot of moving numbers here, and there's a calendar year, the fiscal year, the Medicare year. So I can say that again. Yeah,
right now in the governor's recommend, there is nothing related to reimbursement rate.
correct.
So that's one. Two, as of January 1, Medicare has reduced their fee schedule by 3.4%.
Correct.
So if we don't do anything starting July 1st in the fiscal year 25 budget, your fee schedule would go down.
Correct.
Because of that cut.
Correct.
So you are asking, and that is based on that would be the 2024 fee schedule.
Correct.
So you are asking us to direct DVA to use 2023 fee schedule, because that would be no cut, and add the 4.6 index.
Correct.
Okay.
Yes, thank you for saying that so clearly.
Alyssa.
Yes.
Medicare cuts the conversion factor for budget neutrality. But they do add then back in a inflationary, not
Not
the
in-
MEI,
Oh,
but so like if they cut 3% and then they say, but then we're going to give you inflationary of 2%, then really they've only cut 1%. Am I right?
In theory, that would be right. My understanding is that the Medicare physician fee schedule does not have any automatic inflationary adjustment. The only way that would be included is if they change the conversion factor or those work inputs. There's no automatic. Some of their fee schedules do have automatic, for other provider types have an automatic or some built-in inflationary adjustment.
Okay, yeah.
I mean, in theory, if they added inflation, but then reduced for budget neutrality, my understanding is this is a real 3.4% cut. There is no counteracting inflationary increase.
Can I ask what? I feel like sometimes I feel like I'm responsible for all of this because I'm always the one that's like, do this. Would you be, I mean, this is going to happen every single year because we're always at the whim of what Medicare is going to do and what Congress is going to do. So the RVUs are the RVUs are the RVUs. You're not going to change the RVUs.
Right.
Should we be getting away from, or should we be keeping the RVUs but getting away from the rates being set as a percentage of Medicare's conversion factor? And is there room going forward of just the conversion factor being a set amount in time with a mandate to increase like by so often?
Absolutely. And I meant to mention this. We do appreciate, we're going to be meeting with DVHA. Is that just tomorrow? I lost track of where we are in the week. Tomorrow, to talk about sort of longer term solutions to this fee schedule that could look something like that. I don't know if those would be possible in time for this year. But yes, I mean, I think until Congress, if ever, fixes this at the federal level, I would love for there to be a more kind of consistent solution to this than coming here every year to have to ask you for your input on the issue.
And just so I'm clear, you're asking for Medicaid to change their rates on July, not wait until January of 2025, which is
Correct.
typically when they change their rate.
That's when Medicare changes. Medicaid is typically July, sometimes January. They've done both. They used to, for a number of years, they wanted to try to do it January 1 to be as close as possible to Medicare. The problem is that information comes out so close to January. I think there were sometimes challenges of implementing that, within just weeks of getting all of Medicare's formula. So some years it's been July. So they did make, again, and we appreciate, I do want to recognize that DVHA did not implement that full 3.4% on January 1, which they could have done if they were matching Medicare. We would have seen much more of a cut already. They sort of held us harmless for now. But again, we would anticipate continuing to follow Medicare as of when they update in July. We would see that 3.4% cut due to the changes in the conversion factor.
Do we know how much dollar wise?
I don't have a dollar amount for you.
Can we get a dollar amount?
We get it from DVHA.
I mean, we'll need that.
Yeah, absolutely. Yep.
Anything else?
I think that was what I had, and then I can.
Yep, let's Susan. Hi, Susan.
Hi there. So for the record, I'm Susan Ritson from Vermont Health First. And Jessa did a wonderful job talking about the technical details, and I appreciate the patience and understanding of the committee with all these details related to providers. It gets really dense at times. We do support, as VMS does, inflationary increases in RBRVS due to the reasons that Jessa has so nicely outlined. I'll just say, from the independent practice perspective, this is, and I think Kelly Lang used the analogy before, paper cuts. This is, and I'd say it's more than a paper cut, but this is another instance where CMS is cutting, then it trickles down to Medicaid, rates go down, and then we have all the administrative burdens, and the independent practices see your higher health insurance costs on the exchange every year. It's all these things that add up, and it weakens the independent practice network, and I'm sure other providers as well. And it's, it adds up. So anything that you can do to, heal some of those cuts, and I know your committee's been working really hard on some of these issues, and so appreciate that. It's yet another issue that providers are having to deal with. So appreciate your attention to this matter.
Great, thank you, Susan. Any questions? All right, so we will, as Jessica said, there's a meeting tomorrow with Diva, and we'll make sure that we get a number and we'll add this to our chart. Leslie?
Just a very quick question, Susan, thank you. I'm reading could you just tell me, I should know this, what's a PFS formula?
Physician fee schedule.
Thank you, sorry.
No, sorry, I thought I had written that out, but I must have forgotten. That's the Medicare
Thank you.
term.
Didn't get it. I was above it, sorry.
Oh,
My
no
fault.
problem.
All right, thank you both for
Thank
that,
you.
and we'll come back to this.
Okay.
Mike, did you get my text?
No.
Do you want to go now? Are you ready or no? You don't have to.
Yes, I can go.
Okay, we're gonna add something to the agenda. Do you want me to take 5 minutes?
I want you to look at the
The healthcare advocate does have an ask, and so since he's here, we're gonna squeeze it in.
Give me 2 minutes.
Okay. I'm gonna put us on mute, but we won't go off live. All right, we're back.
Good afternoon, Mike Fisher, healthcare advocate. Good to meet you all. You caught me off guard. I
Yes,
was
I apologize.
busy typing an email to you.
Well, this, right?
First off, I want to so appreciate this committee's ongoing support for us. It's been really, really valuable to our team. Last year, the Healthcare Advocates Office was level funded, and this year, the governor's recommend is for us to be level funded. He did give us an increase 2 years ago, which was very important to us and increased our ability to do all the things we do. So this year, we decided to go ahead and come and ask for an increase that is based on inflation. And so I will submit this in writing. I have it in writing so that you have some of the thinking behind it, but it is the increase we're asking for is a little bit over 153,000. It would bring the total healthcare advocates funding to a little bit over 2 million. Maybe it's worth just spending a minute, over the last 2 years, we did over 6,500 cases. We saved Vermonters $850,000 through reduced bills and or added benefits. That's direct people who've called our office, and we've been able to save them money, help them get reimbursement for their care. That's on top of I think there've been a handful of times where in this process, the Healthcare Advocates Office has brought proposals to the table that have saved significant dollars for Vermonters. And the one I'll mention, it's now a few years old, but we brought to the table the concept of dividing the individual and small group market. which I'm gonna pay for.
Let's hope not.
But it made sense to do, given the substantial federal subsidies, and it was worth $17 million to small businesses. So that's on top of, that's the sort of on the dollar saved. I will acknowledge we also propose to spend money. I think our recent legislative efforts in partnership with you guys include the free care, the statewide minimum standard on free care policies, which will save Vermonters a lot of money when it's finally implemented next year, next July. And the IHIP program, again, in partnership with you guys. And of course, one more in the middle. That's sort of what I have to say off the seat of my pants. And happy to answer questions.
How many staff do you have now? Answering phones, talking to?
We have 8 lay advocates with a supervising attorney, and a communications, so 8, 9, and a communications coordinator. There are 2 staff attorneys and 2 masters of public health people on the policy team.
So people actually answer the phone talking to Vermonters, about 8.
8 of them.
8 of them.
9 of them, because they are operating under the law license of an attorney. So
Okay.
she's not answering the calls, but she is
Helping with the.
online supporting them on a moment-to-moment basis.
Any questions?
I have a question, but it's not really for Mike. It's more for my understanding of the whole thing. In the governor's budget, he's increased salaries and whatever by 3%. Is that what I'm understanding?
No, he's increased salaries and budget for salaries for state employees
At 3%.
at 3%. Healthcare advocates are not state employees.
Yeah, no, I understand that.
And I
but
don't know
I'm
if
just
it's,
trying
and
to-
I honestly don't know if it's 3%, so I want to put that out there. I don't know what the percentage is.
Yeah, I am clear.
I have the pay act and everything.
Yeah, and I'm curious about what the governor, as you know, balancing against the governor's recommend. I'm just thinking. about that.
Yes. So we pass the pay act every year or 2 years. I don't know how often we do it. And so that is for state employees only.
Right. No, I get it's for only. I'm just philosophically trying to
Yeah.
get my head around what he's willing to accept there, but not there.
And if I could just say, this goes in the wrong direction for my own purposes, but I think pay act costs more than the increase in the budget.
Yes.
I think the pay act is based on the negotiation with state employees.
Yes.
And it costs more than the 3.5%. So
Yeah.
it ends up putting more pressure on the agency.
On everything else.
Yeah.
Yeah.
Other questions? Great, thank you.
Thank you
I
for
appreciate
coming in.
the quickness of that, and we'll get you in writing when you can. That'd be great. Okay, we're done for the day unless people have questions or. Okay, we will be back here tomorrow at 9 a.m. for another full day of budgets.
Thank you.
And